Hello, I'm Dr. Tim Chismar, State EMS Medical Director at MIMS. Welcome to the Maryland EMS Protocol Base Station Update. Thank you for taking a few minutes of your time to learn about our protocol updates for 2022. Before we discuss this year's updates, I would like to take a moment to talk briefly about the Maryland Medical Protocols for EMS. You should know that the protocol development process starts with a multidiscipline protocol review committee. This group consists of EMTs, paramedics, nurses, and physicians from around the state of Maryland. They research, author, and edit protocols. This committee is coordinated by the protocol administrator. I chair the committee in my capacity as the State EMS Medical Director. And protocols are then presented to the statewide EMS Advisory Council and MIMS Executive Director with subsequent approval by the Maryland EMS Board. Most of the content is updated on an annual basis with a go-live date of July 1st each year. However, there are occasions for interim or emergency updates throughout the year. In these cases, the base station coordinators will be notified by memorandum from MIMS. As you view this presentation, I would encourage you to reference the PDF of the new 2022 Maryland Medical Protocols for EMS, which is available on our website. Maryland strives for comprehensive EMS protocols, also referred to as offline medical direction. For example, you have likely noticed that our EMS clinicians may perform many procedures or administer medications without initiating medical consultation. In some cases, they may even terminate resuscitation. We aim to give them strong guidance and training to care for their patients. However, we recognize that we can't write a protocol for every patient presentation or scenario. Inevitably, there are times when an EMS clinician will obtain online medical direction or make a call to the base station hospital for situations in which the correct intervention for the patient is unclear. In these cases, they are seeking your advice and direction. Although the ED is typically very busy, please take a minute, listen carefully, and provide the EMS clinician with the best possible guidance based upon your clinical knowledge. Guide them to do what you would do if placed in their situation. In other circumstances, we require an EMS clinician to consult in order to run a decision by the base station physician. Examples include patient-initiated refusal of EMS. In some cases, the patient lacks capacity to refuse, and the appropriate action is to advise EMS on sedation or additional resources to get the patient transported to the ED for further evaluation. In other scenarios, patients have capacity to make medical decisions, but they may also have high-risk vital signs or injuries. In these cases, please ask to speak to the EMS clinician and the patient together through the radio. Our goal is for the patient to hear you advising them that they should accept transport for further evaluation, although we cannot compel or force them to do so. In this latter situation, you are not there to approve or deny the refusal. Finally, you should know that physicians that provide online medical direction in Maryland are not civilly liable as long as the medical direction is provided without gross negligence, free of charge, and through communications with personnel providing emergency assistance. Now, we'll move on to the protocol updates for 2022. There are some additions, edits, and even a deletion. As you can see, there are about 9 major changes to the EMS protocols this year. I've grouped them into BLS and ALS, as well as ALS only columns here. We'll take a look at each area briefly, one by one. The first update is the critically unstable patient. Previously, EMS would quickly move unstable patients to the ambulance and initiate transport. However, recent literature demonstrates that these patients are at high risk for post-arrival respiratory or cardiac arrest, otherwise known as PARCA. One study found that out-of-hospital cardiac arrest decreased from 12% to 5% when immediate life threats are addressed within the first few minutes of EMS arrival on scene. Additionally, it's notable that most PARCA events occurred within 13 minutes of EMS arrival. It's essential that we intervene early and definitively with unstable patients. This protocol applies to patients 18 years of age or older. A critically unstable patient is any patient who is in extremis or has imminent risk for deterioration to cardiac arrest. Examples of this include patients with new onset of altered mental status, airway compromise, acute respiratory distress, signs of poor perfusion, or at-risk patients in the judgment of EMS. When an unstable patient has been identified, EMS clinicians will stop all movement of the patient. BLS clinicians will obtain vital signs, including pulse oximetry, control external hemorrhage, manage the patient's airway and ventilation, and treat hypoxia and respiratory distress. In addition, ALS clinicians will initiate end-tidal CO2 monitoring, obtain a 12-lead EKG as appropriate for the patient's condition, obtain vascular access and support perfusion with IV fluid or vasopressors, and address any immediate life threats identified on the initial assessment. Next, we'll take a look at the VAD protocol. The ventricular assist device protocol is new this year. An increasing number of patients are living in our community with VADs for longer periods of time. Importantly, the VAD protocol does not address every possible problem that may be encountered. Instead, we focus on high acuity situations and provide guidance for management. We emphasize in the protocol that many patients with a functioning VAD will not have a pulse. Assessment of the patient's mean arterial pressure, or MAP, if possible, or their perfusion status is critical, along with evaluating any alarms on the device. For the patient with signs of hypoperfusion, treatment recommendations include limited fluid boluses up to 250 mL and defibrillation as necessary for arrhythmias. For VAD patients requiring CPR, we emphasize that compression should be manual or hands only and not delivered with an automated CPR device due to the risk of dislodging the device. Finally, we provide contact information for most of the major VAD centers in the Maryland area. VAD patients should be transported preferentially to their home VAD center unless they are too unstable to tolerate the extra distance, or they present with a problem that is completely unrelated to their device. Previously, ACETAMINOPHEN was only permitted for treatment of mild to moderate discomfort in patients 2 years of age or older. With the new change, ACETAMINOPHEN may be given for EMS documented fever, that is a temperature greater than or equal to 100.4 degrees Fahrenheit or 38 degrees Celsius, or for mild to moderate discomfort in patients 3 months of age or older. Importantly, if ACETAMINOPHEN is being administered for fever, EMS must document the patient's temperature and the route by which it was taken. With this year's protocol update, we are emphasizing the use of the left lateral uterine displacement maneuver for patients who are pregnant. If the uterus is palpable at or above the umbilicus, in other words, the patient is approximately 20 weeks gestation or more, this maneuver is recommended by the AHA to reduce aortocaval compression and increase maternal venous return. For pregnant patients with shock, hypotension, or cardiac arrest, EMS clinicians should provide left lateral uterine displacement. This technique increases the probability of a successful resuscitation for the pregnant patient. This year, we will remove induced hypothermia. Previously, EMS clinicians were applying cool packs to the neck, axilla, and femoral areas for post-cardiac arrest patients with return of spontaneous circulation, or ROSC. However, based on the recent literature, including the TTM2 trial published in the New England Journal of Medicine in 2021, induced hypothermia has been removed from the MarylandEMS protocols. This research has demonstrated equivalent outcomes for patients who were cooled to 33 degrees Celsius as compared to those who were kept normothermic with early treatment of fever to maintain body temperature less than 37.8 degrees Celsius. In addition, it's notable that the hypothermia group had similar neurologic outcomes and actually had a higher rate of arrhythmias and hemodynamic instability when compared to the normothermic group. While it is clear that some targeted temperature management may be needed to prevent fever for ROSC patients, this likely does not need to occur until late in the ED course or during ICU care. Droperidol is replacing haloperidol this year. As droperidol is a faster-acting alternative to haloperidol, it does not require combination with a benzodiazepine such as midazolam. The EMS protocols now include it for the treatment of patients with moderate agitation, defined as patients who are irrational and exhibiting behavior that puts themselves or EMS clinicians at risk for harm. Patients must have suspected medical delirium or psychiatric illness in order to receive droperidol. If the cause of moderate agitation is unclear, ALS clinicians are advised to administer midazolam. The dosing for droperidol is 2.5 milligrams IM for ages 13 to 68 years of age and 1.25 milligrams IM for patients 69 and older. Repeat doses may be given with medical consultation. Droperidol is contraindicated for EMS administration for patients under 13 years of age. Notably, we're using lower doses that have an extremely low risk of prolonged QTC or arrhythmia. Nonetheless, ALS clinicians will be advised to initiate cardiac monitoring at the earliest possible opportunity. Tranexamic acid, or TXA, has been added to the ALS protocols this year. Patients 15 years of age or older with suspected traumatic hemorrhagic shock may be administered TXA if they meet all of the following criteria. They must be within 1 hour of injury, must have a systolic blood pressure recorded at less than 90 millimeters of mercury, and they must not have a history of DVT, PE, or known clotting disorder. The dose for TXA is 1 gram in 100 mLs of an appropriate diluent, either D5W, normal saline, or lactated ringers, given slowly over 10 minutes. Importantly, patient transport should not be delayed in order to initiate TXA. When given in this context, recent literature has demonstrated a significant survival benefit for these patients who are in hemorrhagic shock due to trauma. Previously, all Maryland 911 jurisdictions had the King LT. Commercial services were not required to carry extraglottic airways, or EGAs. If the jurisdictional or commercial service desires to switch from the King LT to another type of EGA, ALS clinicians must take didactic and practical or hands-on training. EGAs are alternative airway devices that can facilitate ventilation. As more research becomes available, it is apparent that the answer is not always to provide endotracheal intubation to unstable patients or those in cardiac arrest. EGAs can play a valuable role in resuscitation. To that end, one of the following extraglottic airways must be available in sizes appropriate for all patients from newborn through adult, either the King LT, the iGel, LMA, or AirQ. How many of you honestly remember all of the H's and T's? Well, instead of asking EMS clinicians to broadly think about the H's and T's, this revision to the adult PEA asystole algorithm builds upon the rational approach to PEA discussed by cardiologist Dr. Lippman. This approach defines evidence-based treatments for narrow complex PEA versus wide complex PEA versus asystole. For narrow complex PEA, EMS should consider the mechanical causes of an arrest, such as cardiac tamponade, pulmonary embolus, severe hypotension, or tension pneumothorax. Appropriate treatments include IV fluid, high-performance CPR, and early epinephrine. Needle decompression should be performed in patients with likely tension pneumothorax. For wide QRS complex PEA, EMS should consider toxicologic or metabolic causes of an arrest, such as hyperkalemia, metabolic acidosis, Crush syndrome, sodium channel blockers, medications such as tricyclic antidepressants or TCAs. Appropriate treatments include IV fluid, high-performance CPR, and epinephrine. Calcium chloride and/or sodium bicarbonate may also be given depending on the suspected etiology of the arrest. For asystole, EMS should also ensure adequate ventilation along with IV fluid, CPR, and epinephrine, as many of these cases will be of hypoxic etiology. Finally, the medical consultation requirement for sodium bicarbonate in adults has been removed. However, ALS clinicians are given more direct guidance on when to use sodium bicarbonate. In short, every cardiac arrest resuscitation does not need to end with sodium bicarbonate. In closing, I'm grateful for your support of Maryland's EMS system. Hospital EMS base stations play an essential role in our emergency medical services system. Thank you again for taking your time to learn about our protocol updates for 2022.